Hello, welcome to the International Cardio-Oncology Society monthly webinar. We have today Dr. McClanahan, who is University of South Florida and Moffitt, and she's going to present a very interesting case today. We're going to get her PowerPoint up and we'll get rolling. Thank you.
Thank you for your patience in us getting this started. This case I'm going to present is it's still an ongoing case, so I'm very interested in getting people's feedback on this patient and maybe some different ways we can go forward. But she was also seen at multiple hospitals, so I had a bunch of CDs to load and to get this all ready for today, so I appreciate, again, your patience. I'm a general non-invasive cardiologist, and like you said, I work for the University of South Florida. I spend half my time at Moffitt doing the inpatient consult service, and I also see quite a bit of their outpatient work in our clinic. So still getting used to seeing these cardio-oncology patients, but they are very interesting. So I'll go ahead and get started. Let's see if I can click on it. Oh, there we go.
Oh, how'd you do that?
I just clicked on it.
Okay, great. I can get this out of the way. Just push it over. Yeah.
Okay.
That's good. Good.
All right. This is a case of a 39-year-old Caucasian female. I'm giving you a little bit of background first on her to kind of set up her case. She was, back in February of this year, she developed some back pain and malaise and went to a primary care physician who did some blood work and found elevated serum protein levels. And through additional blood work, there was strong concern, and she was referred to Moffitt Cancer Center for further workup. What's this? Because of her back pain, she underwent an MRI and a PET scan, which showed some infiltrative disease of her bones, but no lytic disease. And by SPEP and bone marrow biopsy, she was diagnosed with IgA kappa multiple myeloma. At that time, she had, as far as her lab work, she had normal creatinine, calcium levels. She had a mild anemia of around 11 and a mildly reduced albumin. I think it was around 3.6. And she, in consultation with the Moffitt oncologist, was recommended to be started on this carfilzomib therapy along with Revlimid and dexamethasone. No, wait, I think. Okay. So just briefly go back to her past medical history. She basically was a healthy 39-year-old. She'd had no other previous medical conditions before, some mild anxiety. They also gave her this obsessive compulsive disorder diagnosis and no previous surgeries. She had an allergy to SSRIs and a contrast allergy. She's a former smoker, quit about 8 years ago, but no alcohol or drug use. Her family history, she had a grandfather who died in his 50s of unknown causes, and her mother has atrial fibrillation. She is married and she lives here in Florida. I'm going to go back and give her medications. I put that on the wrong slide, so let me go. I'll read her medications here once I give this story. So about 3 days after her third infusion of her carfilzomib and dexamethasone, while she was taking oral Revlimid therapy, she presented to the Moffitt. It's an urgent care / emergency room kind of setting that they have at Moffitt. It's a very small hospital. They're mildly staffed to take care of some emergencies. She had complaints of severe substernal chest pain, palpitations, and shortness of breath, which was the first time for her. She was in the process of being evaluated for this chest pain that was still present, and she went into what was thought to be a first ventricular tachycardia by the staff in this center, but it turned out to be actually an idioventricular rhythm. But she was having pre-syncope along with it, and there was also some concern for some mild ST elevations. And this hospital, Moffitt, is not equipped to take care of cardiac emergencies, so anybody who looks unstable from a cardiac standpoint is pretty quickly transferred to the closest hospital, which in this case luckily is just across the street. And so she was immediately transferred to this more equipped hospital across the street for further evaluation. So she underwent an urgent left heart catheterization, which found clean coronaries, and the left ventricular gram showed an EF of about 45 to 50%. There was also a concern by her lab work that she had an elevated D dimer, and so they also did a CT angiogram, which showed no pulmonary embolism and some mild emphysema in her lungs. Now, she also had an initial troponin level of 11 that peaked up at 23 with this. I think at my next slide I apologize for the small, I tried to make this bigger last night, but this is the EKG that she had when she
Somebody read it.
Can anybody give a reading on this if you can see it very well? I apologize for the wavy baseline.
Hey, David Slotsky, what do you think of her EKG, David?
Yeah, I mean, she has a sinus tachycardia. Her axis, I believe, is normal. She has an incomplete conduction delay in the V1 and V2. But other than that, well, let's see, actually in V5 and V6 there is a concern for ST elevation. I don't have anything to compare it to, but I would be concerned about V5 and V6, and maybe a little bit in V4.
Great, thank you. Go ahead.
And like I mentioned, she had some idioventricular rhythms at Moffitt, which was also seen. I think I have a rhythm strip here if it's going to go forward here. So this is some of the rhythms she had, even at this outside hospital.
David would like to comment on this too.
I have one question before I comment.
Sure.
What was the contraction pattern on the ventriculogram? You said the EF was down a little bit. Was it globally hypokinetic?
Yes, they felt it was global. And I apologize for not bringing that CD, because that would have been the one part of it. But I'm hoping to load her echo, which is going to be shown next.
Note that's upside down.
Yeah, that is upside down.
The upper rhythm strip is upside
I'm
down.
pretty good, but I'm not that good.
We were trying to see if we could stump the expert.
That was the way it was loaded into this record. I apologize.
So it looks like, I mean, it's clearly a wide QRS tachycardia rate of about 130, I believe. It's hard to see the lines. It most likely is ventricular. It doesn't, I don't see AV dissociation, but there is a P wave in between one of the QRS, the wide QRS complexes.
Yeah,
So I would say this is ventricular tachycardia.
Okay, great. Thanks, David.
All right. So I'm going to backtrack just a bit to tell you what her medications were, and then we're going to go over the echo next. So she was again taking that Revlimid, and then she was taking this dexamethasone, omeprazole, acyclovir for more prophylaxis for the carfilzomib therapy that's recommended, and otherwise just some vitamins, magnesium, thiamine, vitamin E, and some cyclobenzaprine at night. So otherwise, her only real medications were the chemotherapy agents. So we're going to try to show her echocardiogram.
Let me show her MR first because we've got that more accessible.
Okay.
So we're going to go to my PC.
Well,
and we go to all.
Now her MR wasn't done immediately. That's the thing.
Patient list. And then we go to Kathy Leary, and that's not the one we want. So we go to it's alphabetical backwards.
That's her, Kathy Leary.
Yeah, but it's her echo.
Oh, okay.
And it leads to 0. Nothing loaded. There we go. And look like it.
All right. Well, before I show you this, let me tell you a little bit more about what her hospital course was. So during her hospitalization, her hemoglobin was 10, platelets 184, white blood cell count was normal, her creatinine was normal, her electrolytes were borderline, but pretty much normal. She had a SED rate of greater than 140, the D-dimer of 5.9, which I mentioned earlier, which made people concerned for pulmonary embolism. And we're going to show her echo here.
Go back to the MR.
Okay.
There we go. Somebody else about the MR. See, Dr. Murtaugh, can you tell us a little bit about the MR there?
It's not. Oh, there we go.
Can you see that okay?
So basically, we're in a. It's just not playing very well at the moment. I presume that's what everybody is seeing.
Yeah. Can you see the wall motion, or can you see any motion at all?
So it's a 2-chamber SSFP. I have to say, at the speed it's playing, it's hard to tell. But it looks like she has her overall EF is not as bad as I thought it was going to be. But honestly, is it just me or is it playing really, really slowly?
Yeah, I can't tell you what you're seeing because I don't have a slave monitor, so all I know is what I'm seeing, but I think it's probably going to be about the same. And we're getting some feedback, unfortunately. Let me give you some more images.
Okay.
Let's see, to get this.
4-chamber SSFP.
Put it this way.
With RAP. Not much of an effusion anyway, I don't think.
Let's go find another one. We'll give you some more images to help you.
Yeah. Initially on the 2-chamber, I thought maybe her anterior wall was a bit hypokinetic, but it was playing literally one image every 5 to 7 seconds. So.
This is a black blood image. We'll talk a little bit about this. This is a black blood image which is used to look at anatomy. And so you can look at four-chamber view here. You can look at the left ventricular wall. And it gives you just a sort of an overall idea of anatomy. Left atrium looks normal size. The aorta looks normal size. We can see the right coronary origin over there. And you can see the left anterior descending and a little bit of the circumflex. We almost got the main left coronary origin. And the ventricular septum, which looks pretty normal. Ventricular free wall is over here. And this looks a little thickened out here. I'm not sure why that is, but there's a little thickening up here in this area. Then I come down here and it looks pretty okay. Let's go find another image. So looking at this image, which is a short axis type image. And it probably is an image stack. And I'm trying to mobilize the stack, but I don't, here we go. Let's see if it'll cine mobilize the stack. There we go. Now we're going through the stack and just going from, so this is for anatomical as well. We'll try to show you as much as we can here. This is a T-weighted study of some sort. And this basically shows this, trying to get it bigger, shows this area of thickening over here, and it looks like it's got some, if it's this T-weighted, it may have some edema in it. I've never seen this study before, so I'm just sort of winging it as we go along here. Oh, here comes a FAT-SAT study. So, in terms of fat saturation, I don't see an area that's fattier than any other area. So I can't say there's any local deposit of fat. Let's move along here. We'll get some more studies from the bottom here. And this may be a late gadolinium enhancement study, because we certainly do have some nulling of the left ventricle. If that's true, then there may be some septal gadolinium enhancement there. And this is not a stack. This is just one single image. So, but it looks like they did a look locker, nulled the LV, and have some septal late gadolinium enhancement for whatever reason there. Let's go back. If you've got more information, Angela, let me know, because I'm just looking at what we see here. Here's a cine. And this is a cine loop on this image. It's just looking at specific areas. So let's go back to the original. That's not a very good picture to see an LV. Let's go back to the original images that we had, and we'll characterize LV contractility. And here we go back to the original, and here we go to cine. And I hope your wall motion is better with this image. And so what we do see is this area of hypokinesis of the anterior wall that, one, doesn't have the thickness, nor does it thicken, and doesn't have very good motion. And in this particular image, posterior basilar area, inferior wall seems to be beating pretty well. So I'll give it back to McClanahan, who basically have studied this with the radiologist. Go ahead.
Okay. All right. Well, this I had to give you a little bit of a timeline for this study. In this hospital she was admitted to, they did not have good cardiac MR, so she had an echo done, which we can show. But the presumed diagnosis was, because of her clean coronaries, was an acute myopericarditis. Now, at the time, we did the MR to kind of confirm that, but we did treat her with a little bit of carvedilol, lisinopril, and some colchicine for symptomatic relief. We talked to her oncologist about her medications and also the treatment of the myocarditis. She had pericarditis-like symptoms, so that's why we thought about using the colchicine, which actually gave her really good relief of her symptoms. They did not want us to use any NSAIDs due to her myeloma and her kidneys. They didn't want to take a chance on those. We're going to show her echo here.
After a very laborious method of getting to it, we're going to show it.
So the timing of the MR was about 2 weeks after her initial presentation. So the MR that we just showed was about 2 weeks after this initial presentation. At the point of the MRI, she was feeling symptomatically better, but she had been stopped on her chemotherapy at this time.
Okay, so we have an echo. David, I was going to give you this echo, if I can get everything moving for you, so I'm going to take you off of mute, and we'll get the echo moving here. Hang on.
I have a question for Angela while
go
she's
ahead.
pulling that up.
Yeah, go ahead.
So it was interesting on the last image that Eric showed. It almost looked like the bases were contracting better than the lower anterior and inferior apical wall. Do you think there was a Takotsubo type of syndrome here? She didn't have late enhancement, so I don't know that myocarditis really was proven. She responded to the colchicine, which would suggest pericarditis. But I just wondered about that contraction pattern on the image.
Well, see if you look at the echo and think so, because her EF was never really found to be less than 45 to 50%. So she never really had that severe kind of apical ballooning that you would think along for Takotsubo. And
the image that's up now, look, it's going very slowly, but you're right. It actually looks more diffuse.
Yeah, and that's why Takotsubo was a thought for a short time, but with her contraction pattern, and she had really no congestive heart failure symptoms. Not that they always do, but she didn't. Hers were more in the chest pain kind of symptoms. We may have just not gotten to the part of the MRI because that showed the late gadolinium enhancement, because the radiologist did feel that there was some patchy mid-myocardial, subepicardial late gadolinium enhancement. So they did feel like it was present on that MRI. We may have just not gotten to place. But they also thought her ejection fraction was normal. So they, at that time, thought it was it was confirmed to even 2 weeks afterwards. Still some of it was present. And
Yeah, the concern, are you going to talk about the carfilzomab?
yes, because that was the kicker about that. It gets a little bit more, as we go along here, there's a little bit more complexity to it, because she was on the Revlimid and the carfilzomib, and it was like, which one is the insulting agent?
Right.
Have you seen many patients? Yeah, go ahead.
The echoes that you're showing, I mean, other than the mild hypokinesis, looks like a normal echo.
Yeah, that's pretty much all along. She's never had any severe reduction in her ejection fraction. It's always kind of been upper 40s, low 50s, and just more of like a global. Now, the radiologist on her MR did try to say that there was some mild wall motion abnormalities in the mid-anterior and inferior lateral walls, but I never felt that was confirmed with the echo.
Yeah, the FDA actually put out a warning about a year ago on the carfilzomab. I think there were nine heart-related deaths.
Yeah, I have that.
That were receiving.
Yeah, I do have that. I have that study. It was in this Hematologica journal that was reported on a study of like 526 patients, and there was quite a few that did have cardiac-related toxicities. Now, they never specifically mentioned myocarditis as the way it's, the way the toxicity occurs, but that was the first concern with her, was that carfilzomib.
Yeah, Dan Lenahan's not here. I thought he was going to be here, but he's had one patient that had congestive heart failure on that drug.
Yeah. So I saw her about a week and a half after she was discharged from the hospital, and she had been feeling really well since she'd been home. She finished 1 week course of colchicine. She did have to stop the lisinopril because she was a low blood pressure kind of lady. She's very thin. She did continue on the carvedilol and was able to tolerate that. So again, that cardiac MR we showed was about 2 weeks after her initial presentation, but we thought it was still worth doing to see if we could get a more clear picture of what may have caused her symptoms to start with. So the radiologist did feel that there was a little bit of late enhancement on that. This was her ECG in my office. This is probably unreadable by you guys. I really tried to brighten this up, but this was her EKG in my follow-up.
Change it. You'll have to read it because I can't. Whoops.
Yeah, I really can't see anything.
Yeah, I mean, it's just pretty much, again, this was normal sinus rhythm. She had some T-wave abnormalities in the lateral leads. She had, the slight interventricular conduction delay, but otherwise it looked better. And this was the MRI reading. Again, I kind of already summarized that with them saying that there was patchy mid-myocardial, subepicardial late gadolinium enhancement involving the basal and mid-myocardium with sparing of the apex. These findings are suggestive of myocarditis, which could be due to infectious, toxic, or autoimmune etiology. Similar features can also be seen with sarcoid, but less likely in the clinical setting. Normal resting first pass perfusion, no myocardial edema on T2 inversion recovery images, normal right ventricular size and systolic function, and no valvular abnormalities. So the following month, the plan was to restart her on the Revlimid and dexamethasone, obviously leaving out the carfilzomib. But within a few days of restarting the Revlimid, she again had recurrence of chest pain and palpitations. Now, she said it wasn't to the same degree as her first episode, but it was still a definite change from what she was feeling before. They did another CT scan to rule out pulmonary embolism, which was negative, and she had another echo done in my clinic in July 1st, which showed basically almost the same exact as the echo before, just some mild global hypokinesis, but nothing that seemed to be worsening at all. And they gave her another small course of colchicine, but there, of course, was a concern that the Revlimid was giving her these symptoms also. So it kind of, you know, it frustrated everybody that we thought the carfilzomib was the actual one causing her symptoms, but now it seems the Revlimid was causing it too. But the oncologist was very frustrated because even on her short courses of the medicine she'd been on just for a couple months, she had 87% response to her myeloma in just that short course. And so they were really wanting to continue her on these medications in order to get this completely cleared. So after she continued with chest pain, they ultimately stopped the Revlimid, and they continued her on the dexamethasone alone. A repeat cardiac MR was done here at the end of August, which I have pulled up here at the bottom, but it may be another chore to try to pull this one up also.
That would be which one here?
I don't think that one. That's the old one. I think we have it in, if you lower the screen.
Bring this down.
It's behind all of these things.
Close that out.
Just maybe minimize mine.
Okay. Never close anything.
I think we're overloading the computer. She had literally the MRIs done in two separate.
Right.
No, that's my presentation, but that may be enough to show it.
All right.
Yeah, that may be. I have some summary slides that were nicely given to me by. By this point, the oncologist at Moffitt was very frustrated and kind of felt like he needed a second opinion in regards to this case. So the patient was willing to go up to the Northeast to be seen at Dana-Farber for a second opinion. At that point, they did repeat lab work and an echocardiogram, and they also had copies of both MRIs that she had gotten done. So the echo there, they had said she had completely resolved her EF back up to 55 to 60%. And these are her two MRIs that that they summarized here between May and September. So on the left is the May one, and they thought that that there was late gadolinium enhancement involving the mid-septal anterior and anterolateral segments, and a mid-wall subepicardial pattern. And then in September, they thought there was persistent late gadolinium enhancement and a similar pattern. Does anybody have any comments about these pictures?
So y'all can see that this area looks pretty good here on the A, and then we go to the, and that's a section that they made, and then we go to the B, and you can see clearly this area of late gadolinium enhancement coming around septally. This is the right ventricle, this left ventricle, coming around laterally and coming around inferiorly, and sparing this area here perhaps. And then this is the same, except it's more magnified, so it's a bigger image. And we don't have as much in the septum there in terms of late gadolinium enhancement as we had over here. But this pattern is pretty much the same, and the other pattern is pretty much the same. So indeed, there's a large area of LGE indicating some scar tissue or some extraneous tissue that's in there that's causing more interstitial space. Then you have to decide what that is. Okay?
And here's another summary screen of the, I think, the septal.
Yeah, that's exactly the same that we saw on the previous study that you did 2 weeks afterwards at somewhere over there that we showed on the workstation. And so we saw this very clear mid-septal area of late gadolinium enhancement, but no edema in there. So it's a localized area of, which is very nonspecific, but it's a localized area. I mean, that could be, for all I know, myeloma cells, for that matter. Or it could be some damage to the muscle.
And I think there's, again, this is the third one.
And then again, we see the same thing. The very marked pattern of diffuse. This is more subendocardial over here on the right side of the septum. And this is more subendocardial as well here. And all of it being late gadolinium enhancement, and there being no T2 weighted abnormality that was presented, which meant that there's no edema.
Should we let anybody else comment? How do we let other people comment?
To get somebody to comment, you have to unnull them, so it's chaos.
Does anybody else have any comments about the MR?
Yeah, I do. Shireen here again.
Yes.
There's a question.
So the late GAD, to me, is extensive. And from the first MRI, considering that was 2 weeks,
Oops, that's her. I'm sorry.
I think that's quite dramatic.
Uh-huh.
The mid-wall pattern that she shows, and the kind of extent of, it doesn't actually look sub-endo to me. It looks predominantly mid-wall and even sub-epi. So I can see why they're questioning an atypical amyloid pattern. But really it looks like pretty straightforward myocarditis. And I don't know about there not being any T2 high signal. I mean, looking at those black floods, I think she does have a bit of edema. I do. But the late GAD is dramatic. And if she has that amount of GAD persistently at this time, that's not great resolution at all. So how much steroid or how long has she been on steroid?
She's basically remained.
First MRI.
She's remained on the dexamethasone almost the whole time, except for maybe a 2-week period without the dex. The other issue is she had only about a 2-week period off that Revlimid, but was restarted on it. So there's a question of whether or not that has kind of persisted this inflammatory response, because the carfilzomib was stopped, but the Revlimid was continued until very recently. So there's also a concern that maybe that's contributing to the continued inflammation. Now, we don't know which one caused the initial insult, but the Revlimid seems to be playing a role also in her. I don't know if anybody else has any experience with that, with Revlimid.
Tammy, do you have any experience
No, I
with
mean, we know that
Revlimid?
carfilzomib has a warning out on it, but mostly for ischemia.
Do you have any experience with Revlimid?
Okay, I'll have to. Great. I have the T2 weighted image up on another screen, on another computer, on another workstation, which is a vital workstation, and I'm able to dial up and down the intensity, and I can clearly see that there's large areas of edema in this heart. So I just wanted to comment and verify what Dr. Murtaugh was saying. There's large areas of edema here. Once you dial down, see, this is normal myocardium, and that's the edematous area. So there are large areas of edema. I apologize, we didn't have a very good image before.
So the Dana-Farber oncologist, there was a cardio-oncologist and a myeloma oncologist who saw her, and they thought her initial severe episode likely was the carfilzomib, and there was a question of whether the Revlimid was continuing just an inflammatory response that didn't allow it to resolve. But their recommendations were to give her just kind of a break from both of those for about 6 months and continue on the dexamethasone with the Zometa for this time period, and then a consideration of this bortezomib, which is similar to the carfilzomib but thought to have less cardiac side effects. So that's going to be the possible next step for her in about 6 months. And that's pretty much up to date of where she is as far as her treatment. And like people have been mentioning, the big study that came out about a year ago on the carfilzomib in this hematologica journal by Siegel found the most common side effects with carfilzomib were pneumonia, renal failure, pyrexia, there was congestive heart failure, dyspnea, hypercalcemia, and fracture. But there were some more cardiac-focused ones that led to discontinuation, congestive heart failure, dyspnea, renal failure, and cardiac arrest. And there was some controversy about how many deaths, but they said up to 8 deaths could have been contributed or related to cardiac. So that put a pretty big warning on this medication. Nothing I could see was ever mentioned about myocarditis specifically, but you wonder if maybe this was one of the mechanisms could be the myocarditis, especially since she had those unstable rhythms with it also. There was also a couple studies on in smaller journals of the Revlimid. There was a case report of an 85-year-old female who had multiple myeloma on Revlimid. She died from fulminant myocarditis, and she had a post-mortem that showed that confirmed the myocarditis, thought to be immune T-cell infiltration of the myocardium. There was a second case report of another 69-year-old female that also had sudden cardiac death in her sleep while on Revlimid. So there are very limited data on this, but also both concerning for cardiac etiologies of these symptoms. So again, this is an ongoing case, and I thought it was kind of interesting, and I apologize for all the random imaging because they were all done in different places, and I didn't get them loaded here very well. So I'm open to questions and any comments about this case.
I've unmuted all the participants.
I presume she's been too coagulopathic or something to biopsy?
That was also brought up too. It still could be done if we felt that her condition was changing. We have limited places in Tampa that do these cardiac biopsies, so it would have to be another referral. But it's definitely a consideration. I agree with that. But it's not been done yet.
I think, I'm going to stop talking in a minute, but she's got one of the worst late-added edema patterns I've seen in a long time for a patient like this. Her entire heart is extremely inflamed, and you'd have to worry about how pro-arrhythmogenic all those areas are. I totally agree with keeping her on the steroid, take her off any possible precipitants. You just cannot risk giving her anything else that could precipitate further fulminant kind of myocarditis type picture. Her picture's very concerning. I would biopsy her personally. I would definitely send her for a biopsy. you just don't know exactly what you're dealing with. But her GAD had barely abated at all, despite what you're saying is a lot of steroids. We're used to seeing much better responses. So she certainly strikes me as a young woman who's high risk and needs to have as many investigative procedures to confirm this diagnosis as possible. Although the argument would be, of course, what's it really going to change? You're just going to leave her on steroids for 6 months anyway. So I guess what would be more reasonable is we'll keep the MRI. If there's zero resolution, at that point I would consider a biopsy. I think you guys have done a fantastic job. It's a shame she had to wait 2 weeks for an MRI, but thanks for presenting a really, really good case. It was great.
Oh, well, thank you. And there was also a mention on this last MRI by the radiologist that they couldn't rule out atypical amyloid, but the oncology side of things don't feel like this was a typical amyloid picture, but that was also kind of thrown out as a possibility.
In terms of biopsy,
it was great to know.
The biopsy is an interesting idea. In terms of that, when you look at the MRI, you can find several areas in the left ventricular septum that are exposed to right ventricle, and it looks like if you did MRI-guided biopsy, which they can do at several centers, if you did MRI-guided biopsy with non-ferrous materials, you'd be able to target the best site and be much more specific in getting a sample that would be positive. And any comments about MRI-guided biopsy? Unmute some people. I think David is gone. I want to welcome Camelia Peterson, who's here from Alaska, and Michelle Arcopinto. Thank you very much for coming. Any more comments that you'd like to make? If you hold up your hand, I can recognize where you have a question. There's a little spot where you can click to hold up your hand, or another spot to click for a question. Unfortunately, I have to keep people muted because of the background reverberation. I guess we don't have any questions. Okay. Here's a question. Okay. Dr. Murtaugh?
I think looking at the MRI, even without real-time MRI guidance, you'd have a good chance of getting something that would be positive and could realistically influence what you're going to do with this woman in future. Certainly, we don't do MRI-guided cardiac in Chicago. As far as I know, anyway, I don't think we've done it, but it seems like a great idea.
Yeah, there's several groups that have been involved in MRI-guided radiofrequency ablation of atrial fibrillation, and certainly trying to do that as best they can in Utah, the University of Utah, with the Karma group, and then there's a group in Boston that's pushing the edge of radiofrequency ablation with MRI-guided. So there's a great future there. Listen, I want to thank everybody for attending. I think we've overrun our time a little bit here, and so we really appreciate your attendance and your bearing with us on the image presentation. And I want to certainly thank Angela McClanahan for being part of our presentation today. We will be getting back together again on a Thursday for continuing to put together practice models for cardio-oncology, where we've been writing that document with Dan, and so you'll hear more about that, and you'll get an invitation for that meeting. Thank you so much for attending, and have a good end of the week. Bye-bye.